Thank you very much, guys, for joining us. Let's start with Dr. Peter Millett.
Great. Thank you for the kind introduction, Usama. I'll share my screen here. So I'd like to thank the Emirates Orthopaedic Society and the Dubai Shoulder course for inviting me. It's fun to see all my friends from the Middle East. I wish it was in person, and I look forward to the day when we can all meet again in person and share stories about shoulder surgery and life. So I had the privilege of being in Dubai a few years ago, and it was a wonderful experience, and I look forward to visiting again. So I'm going to talk today about anterior superior rotator cuff tears and subscapularis repair. These are my disclosures. I am a consultant and receive royalties from Arthrex, and I receive royalties for some books that I've written, as well as stock in ViewMedi. So the goals of rotator cuff repair really have not changed significantly from what I learned as a resident. It's the techniques have changed dramatically, and the goals really are to restore the anatomy, to restore the biomechanics, to achieve strong fixation, to promote healing of the tendon to the bone, and to achieve pain relief for the patient and improve function. The evolution of rotator cuff repair has been quite substantial. We initially started off with single row repairs using anchors that were not really designed for the rotator cuff. Then we used a double row repair with unlinked anchors. This is what I learned when I first started practice. And then around 2003, we came up with the concept of linking the medial and lateral rows, and we published this in 2004. And this has now evolved into these so-called crisscross configurations, double row with a knotted repair, and now we use a knotless type of construct since 2008, and we've had very good success using this. This is the link construct using a crisscross configuration that is now so familiar to all of you, and was started this in early 2003, and we published the technique in 2004. Shortly thereafter, Lisa Galitz from the University of Washington published the results where they looked at arthroscopic rotator cuff repairs using single row techniques, and they looked at them using ultrasound, and they found that 17 out of the 18 patients had recurrent cuff tears. And at 2 years, only 12 of the patients had ASCS scores greater than 80. So it really made us start thinking, were we doing the right thing by going to arthroscopic repairs? And I think some of the technique evolutions that I'm going to share today show how we've dramatically improved from what we had in 2004. So in 2020, we have a double row, knotless linked self-reinforcing repair. We use suture tape quite frequently. We use optimized anchors. And now I think we can achieve predictable outcomes. We minimize the surgical steps. We maximize the tendon to bone fixation strength. We optimize tendon to bone healing. We have better surgical precision and speed, and this results in improved outcomes for our patients. What are some of the advantages? Well, we have improved suturing techniques. We've figured out how to optimize the suture pattern. We have the sutures on top of the tendon, compressing it back down. We've learned about different types of knots, and also we now have knotless constructs that are decrease the variability in how strong the repair is. We've learned about tear patterns and how to do margin convergence. We now routinely do double row fixation to improve the surface area for healing. And we optimize the anchor placement sites with anchors placed medially at the articular margin where the bone is good, as well as laterally where the bone quality is good. And we also create these constructs which are self-reinforcing, much like a Chinese finger trap. The harder you pull on this construct, the harder you pull on the tendon, the more it compresses the tendon into the bone and the stronger it gets. Tear pattern recognition is really crucial for anatomic successful rotator cuff repairs. They're not all crescent-shaped tears. Sometimes you have U-shaped, you have L-shaped, you may have a chronic L-shaped tear, you may have this massive retracted tear, and each of these requires a different strategy for repairing this in a low tension, type of repair to get it back down onto the footprint. The linked constructs, as I mentioned, have this self-reinforcement that Steve Burkhardt has talked about. This results in less suture cut through and less load per unit area with a decreased risk of the so-called type 2 tears where it tears medially. You also have improved vascular inflow to the healing tendon. Most of the healing occurs from the bone up into the tendon, so there's no foreign materials at that location with this type of repair, and that improves the ability for these tears to heal. You also have no overtensioning with medial knots. You have less irritation in the subacromial space, and the tapes act as actually as a bioscaffold. They have greater stiffness and greater ability to resist load, and they also are very fibrogenic. New fibroblasts grow onto these and they act as a bioscaffold for new tissue and growth. The self-reinforcement has been studied in the lab. Principally, Ty Lee and Max Park have looked at this. They've looked at constructs with single row and linked double row repairs, and they found that you get better self-reinforcement with loading using these linked constructs, meaning the harder you pull, the more it compresses the tendon back down onto the footprint. I like to think of these like safety nets that line the ski hills where I live. Multiple rows, multiple fixation points, and it's all linked. So when load is applied to one portion of the tendon, it gets distributed over the whole construct, and therefore the tendon is less likely to cut through the repair. We've looked at this, and a number of others have looked at this, and this was a systematic review of over 567 patients. At 2 years, there were similar clinical outcomes, but the re-tear rates were much lower when double row was compared with single row repairs. So if your goal is not only good outcomes, but also lower re-tears, structural healing, the double row repairs improve that. And Ryan Worth should be credited with doing this nice study. This is a knotless repair of mine. This is a right shoulder. I do it in the beach chair position, viewing from posterior laterally. I use 2 lateral portals, an anterior portal and a posterior portal, prepare the footprint, prepare the tear. Here's one of the anchors going in medially at the articular margin. This is the posterior anchor going in. I then retrieve the sutures out one of the lateral anchors, out the lateral cannula, and pass it through the tendon. And we'll then pull it over and compress it down. So we take one suture from each of the medial row anchors in a crisscrossing configuration. We then tension this back down onto the footprint and then cut it flush. I'll then retrieve one of the tapes from each of the medial row anchors, and we'll then do our posterior or anterior lateral anchor and secure this back down. And this is what a typical 4-anchor repair would look like using these specially designed anchors and suture tapes. We looked at our 2-year results with this. We compared, originally we were concerned that maybe the knotted repairs would do better. The knotless tape repairs wouldn't be strong enough. But what we found that there were excellent clinical results with both constructs. And we found that in this study, the tape bridge had a higher ASCS score as compared with the knotted suture bridging construct. In this series, we had 7 shoulders, 4.4% that needed revision, and similar results in both groups with knotted and knotless. So this gave us confidence to move forward with the knotless tape bridging constructs because we had better clinical results and equivalent revision rates. When we looked at this study, looking at structural outcomes as well, we did not see a higher failure rate. We actually saw a slightly lower, but not statistically significant, lower rate of success using the tape bridging construct. More recently, this is unpublished data. It's been accepted for AJSM. We now have minimum 10-year outcomes with these transosseous equivalent repairs for full thickness supraspinatus tendon tears with or without associated infraspinatus tears and subscap tears. And we had 91 shoulders that were minimum of 10-year outcomes Mean age was about 61, and average follow-up was 11.5 with a minimum follow-up of 10 years. What we found was that even at 10 years, we have excellent clinical results. Pre-op ASCS scores went from 61 to 93, and our revision rate was only 5.5% at a minimum of 10 years. We did not see a difference in the outcome scores, again, between knotted and knotless, suggesting that the knotless repairs perform excellently. And we found on a Kaplan-Meier survivorship analysis that we had 95.4% survivorship after arthroscopic rotator cuff repair at a minimum of 10 years. So we've come a long way from what Dr. Gallath showed in 2004, where now we are getting very good, successful outcomes for our patients with predictable outcomes and low revision rates and high satisfaction rates. These types of repairs, I think, are adaptable. Not all rotator cuff tears are equivalent, so you need a construct that you can adapt. Sometimes you'll have a dog ear, you can put an extra suture in to account for that. You can do these extended bridging constructs for larger tears. If you have complex tear patterns, you can tie knots. You can also put this under a patch to augment a repair for people with tendinopathy, or in a revision setting where they have a short tendon and a healthy muscle where maybe your tendon is compromised. You can add in a patch as well. Healing does occur quickly. I showed this earlier. This is a patient of mine from a number of years ago when I was first doing these repairs. It's a right shoulder. He had a crescent-shaped tear, and we did a double row construct here. In this case, this was before we had the biocomposite anchors, and we use a PLA anchor, but here you see the repair. We have a little bit of a dog ear here, but at this point, I wasn't sure how to deal with dog ears. At 6 weeks later, he had an injury to his shoulder and got an MRI. It was read by the radiologist as a re-tear, so we went back in to scope his shoulder. And you can see here the footprint is restored. It's back down to the articular margin. The tape is in place. You can see there's neovascularization. And this is what it looks like at 6 weeks with all this tissue secured over the tendon, and you see the tapes completely encased in new tissue. There are some technical pitfalls. You can put the sutures too close. You can have dog ears, you can have soft bone, or you can have lack of tension. All of these can be addressed. I typically will spread the sutures out about 1 to 1.5 centimeter intervals now. Dog ears can be addressed by trying to do a provisional reduction and seeing if you're going to have a dog ear, and if you are, place an extra suture in that dog ear and that's just incorporated in your lateral row. Soft bone, I personally like to use a punch. If I have an older patient, I can get a sense for what the quality of the bone is. If the bone is soft, I'll use a smaller punch, or I can go to a larger anchor, a 5.5 anchor. If you have lack of tension, that doesn't usually occur with smaller tears, but some of the larger tears can occur. And if you work from the sides and work towards the middle, it tends to even it out. So I'll tension my anterior lateral anchor, then I'll go to the posterior lateral anchor, and then I'll work towards the middle. And if I do that carefully, I usually don't have a problem with the tension mismatch. Poor quality tendons, sometimes more complex suture patterns can be helpful. Placing additional sutures where you tie a knot, or changing an L-shaped tear into a U-shaped tear by tying margin convergence sutures can be helpful. As I mentioned, the poor quality bone, you can use cortical augmentation. You can have different anchor sizes. Also, connecting the anchors dissipates the force over the whole construct. We like to try and optimize the biology locally by using vented anchors. I will make sure that the bone is healing well, and bleeding. So I frequently will do a microfracture if the bone is very sclerotic. If I debride it and it's bleeding well and it's soft, I just stop at that point so I don't weaken it. And then I also am very careful to address associated pathology such as the biceps. We also are always careful to look for subscapularis tears and repair them when needed. The potential causes of subscapularis tears are trauma, prior open surgery where they've had the subscapularis taken down previously. We also look for coracoid impingement and pulley lesions. Pulley lesions occur when the bicep starts to tear through the medial pulley, and then it can start to actually cut through and into the subscapularis tendon. The diagnosis is usually made by physical exam with a detailed history and a careful physical examination with tenderness over the lesser tuberosity. In massive tears, then they have weakness in internal rotation. They may have increased external rotation passively. You can also look for a positive belly press, lift off, or bear hug test. Here's a patient of mine with a chronic subscapularis tear. You can see here his belly press is positive. He also has a positive belly off sign where he's unable to hold his hand against his abdomen because he has a chronic subscap tear. He also had increased external rotation, and this was due to a subscap avulsion injury that occurred 20 years earlier when he was approximately 13 years old. The subscapularis rupture can be seen by imaging. Radiographs, you can look for narrowing of the coracohumeral interval, but typically the most helpful is an MRI, particularly the axial cuts or the sagittal oblique cuts. We look for retraction, atrophy, and then we also look at the coracohumeral interval. You can see a narrowed coracohumeral interval in this image here. Imaging of the subscapularis can be shown with high sensitivity and fairly high specificity. As I mentioned, the axial cuts are helpful, as well as the sagittal oblique cuts here to look at the insertion of the tendon on the lesser tuberosity. The classification we use is typically the Lafosse classification, with type 1s being partial lesions of the upper third. Type 2s are complete lesions of the upper third. Type 3s are complete lesions of the upper 2/3. Type 4s are a complete lesion, but it's centered and the Goutelier is less than or equal to 3. And then a type 5 is a complete lesion of the tendon with eccentricity of the humeral head and significant fatty degeneration greater than Goutelier stage 3. These typically require some type of tendon transfer or a graft in the front to restabilize the humeral head, or consideration for reverse shoulder arthroplasty. The goal of repair with the subscap is, again, to restore the anatomy. The subscapularis has the largest footprint on the humeral head. You can't see the entire footprint from inside the joint. This is something to consider. So sometimes it's blocked by the inferior capsule. So some of these, if they extend pretty far down into the lower portion, lower tendinous portion, or even into the muscular tendon, the muscular insertion on the humerus, it can be difficult to visualize because you have the capsule covering that. And this is a study by John Wright just showing that. And in some cases, I still will do an open subscap repair doing a delta pectoral split for that reason. The imaging, we get an AP, an outlet, and axillary. We look at the coracoid. Here you can see evidence of the coracoid prominence, which may be indicative of subcoracoid impingement. You can look at the coracoid index, which is the distance tangent to the glenoid surface of the coracoid tip, so how far lateral it extends. You can also look at the coracohumeral interval, which is the interval between the tip of the coracoid and the lesser tuberosity. And if it's narrowed less than 10 in a man or less than 8 in a woman, that can be a contributor to subscapularis impingement. And this can be affected by the position of the humerus relative to the glenoid. So it's always good to make sure that the humerus is centered, because the coracohumeral interval can be narrowed primarily, or it can be narrowed secondarily due to anterior translation of the humerus. We looked at this showing that a coracoplasty was indicated when it was less than 10 millimeters in men and less than 8 millimeters in females. And it was highly correlated with tears of the anterior superior cuff, subscapularis tears, biceps pulley lesions, and long head biceps tendon pathology. Here's an example of a patient. This is a right shoulder. This patient has an upper subscap tear, and we performed a coracoplasty. Here we're debriding the subscap. You can see the split that's occurred there, and this is an upper tear. And in this case, we then went ahead and decided this subscapularis needed to be repaired, but we always look at the coracohumeral interval as well. And you can see in this case that it's quite narrowed. It's only about 4 to 5 millimeters. So in this case, we clear that space, and then we'll also perform a coracoplasty, anteriorizing the coracoid and medializing it so that it will not impinge. This also facilitates your arthroscopic repair of the subscapularis tendon by creating space so you can work in the subcoracoid space as well. And this just shows using typical anterior portals. I'm viewing from posteriorly, working through the rotator interval, and we can remove the posterior aspect of the coracoid. We always try and preserve the conjoint tendon attachments as well as the CA ligament attachments, but you can see more space here, and it creates space so that you can do your repair of the subscapularis. The comma sign is something to look for. This can be helpful in these larger subscap tears. It's a tissue formed by the superior glenohumeral ligament and coracohumeral ligament, and it frequently will get scarred to the deltoid fascia. So if you free this up and maintain it and then pull it over, a lot of times you'll put your camera in through the interval here because the tissue is retracted medially, and you may have a hard time identifying exactly where the subscap is. If you put a grasper in and pull this over and then identify where the normal interval is, then you can make a portal here. But keeping this tissue intact and pulling on it can be helpful to form a appropriate reduction of this subscapularis. Here just shows viewing for an arthroscopic repair. You can either do an intra-articular repair or an extra-articular repair. This would be an extra-articular repair here, viewing from the subacromial and subcoracoid and subdeltoid space. Most can be repaired with an intra-articular repair. Most of the tears I see are partial thickness upper third tears. I always do a tenodesis of the biceps tendon if it's unstable, or if it looks like it has a medial pulley lesion, I prefer to do a subpectoral tenodesis. And this just shows a case here. This is a case where there's a coracoplasty being performed. I retract the tendon laterally, pass a suture with a PDS suture through the tear, and then we can shuttle our tape through the upper third of the subscap, retrieve those out through our anterior superior portal. And then at this point, I can then prepare the lesser tuberosity and then create a bone socket with a punch. And at this point, I then, usually I'll use a knotless anchor and just dunk that into the bone socket and secure it back. And that's probably 80% of the subscap repairs I do. I always clear out the subcoracoid space, and if it's narrowed, I'll perform a coracoplasty as shown in this case here. And that's a typical intra-articular repair. Extra-articular repairs, we establish an anterior subdeltoid space. This is typically done for the larger tears that maybe go behind the capsule so you can't see them. And we'll typically view from this portal or this portal and visualize the subscapularis down here in the anterior space, and you can follow the CA ligament down to the coracoid to help you find it, perform a coracoplasty if needed, and then identify the subscapularis tendon. It's always important to avoid nerve damage. You need to know where the nerves are. The motor branches, the subscapularis, actually do come in quite laterally from the plexus, and it's easily injured. This is a patient that I took care of a number of years ago who had an intact subscapularis but had the motor branch of the subscap denervated when she had her repair, and she still had a positive liftoff sign. So here's the neuroanatomy. This is a right shoulder here, the conjoint tendon, the subscapularis and humeral head on the left. And you'll see some of these motor branches coming in off the plexus here, medial to the coracoid, and posterior to it. And here you can see the axillary artery pulsating, and these motor branches come in frequently quite lateral as the axillary nerve, and then the motor branches are going to be right in this tissue here. So you want to carefully protect and preserve those so you don't damage them. This is an example of an extra or a repair of a large tear. We use a combination of an intra-articular and extra-articular repair. This is a left shoulder beach tear viewing from posteriorly. Here we're placing our sutures through the tendon so that we can repair this. I use an Xbox speed bridge type construct in this case, and we'll secure it back down onto the footprint. We'll shuttle the sutures through. Now we're in the extra-articular position here, viewing from the subdeltoid space. We'll retrieve our sutures, which were placed using an intra-articular visualization. And now we're in the subdeltoid space, subcorticoid space, and here's our completed subscap repair using a speed bridge type construct. This is an example here of a massive tear where it went all the way down into the muscular portion. The muscular portion was it was a motorcycle accident where his arm got hit violently, externally rotated, dislocated it, and avulsed his entire subscapularis. And in cases like this where it's really large, I have no problem doing an open repair like this so that I can get a really solid repair. When it goes down really low, sometimes it's difficult to get the appropriate visualization or angle for your anchors. So in this case, we then did a 6 anchor extended bridging type construct here, 3 anchors medially, 3 anchors laterally. We tenodiced his biceps, and here you can see the completed solid secure repair. Subscap repair outcomes are quite good. Chris Cottigan, who's in practice now in Germany, looked up our results. Arthroscopic repair of isolated partial and full thickness upper third tears. These were all arthroscopic repairs. Single anchor repair and biceps tenodesis. 28 patients with a mean follow-up of 4.1 years. VAS score is very low. ASCS scores went up significantly from 54 to 90. And we had significantly higher ASCS scores when they had a type 2 tear compared to a type 1 subscapularis tear for some reason. The technical errors you can make with subscap repairs, again, inadequate repair, inadequate mobilization, inadequate fixation, and suture cutout. So again, these constructs we have now really with the specialized anchors that are designed for the cuff and the suture tapes and the crisscrossing of the sutures really have reduced this. And I think the other thing is we always address the biceps tendon. I think if you fail to address the long head biceps with a subscap tear, you may end up with a patient who has postoperative pain secondary to scarring in the biceps sheath with loss of the normal excursion of the biceps or an unrecognized hourglass or persistent pain just from the biceps tendon. The complications we see, re-tear, impingement, sometimes subcorticoid impingement or scarring, axillary nerve injuries are not inconsequential, and stiffness and scarring or persistent pain. And these can typically be avoided using the techniques I showed. So the keys to success with anterior superior rotator cuff tears and with subscapularis tears are to restore the anatomy, to achieve healing, to avoid complications. We want to treat the associated pathology. With subscapularis tears, it's the biceps and the coracoid. And then if you need to do an open approach, for posterior superior tears, it's rarely needed, but for subscap tears that go down pretty far, I don't think there's much morbidity in doing a delta pectoral approach and getting a really secure repair. So again, thank you to my friends in the Emirates and the Middle East for inviting me. It's really a great honor to be here with you today. I'd like to especially thank the Emirates Orthopaedic Society and the Dubai Shoulder course, and Usama Saleh for inviting me. It's nice to see you all. It's amazing what modern technology can do. I hope that this was helpful for all of you and helps you in the care of your patients. Thank you. I'll give you.
Thank you very much. Thank you very much, Dr. Millett, for this very nice, informative presentation, to the point with a lot of tips and tricks. Thank you very much for sharing your experience with us tonight.
Thank you.
I'll move on to our second speaker. Professor Hatem will share with us his experience on the adds-on with the rotator cuff repair, what exactly we should do with the acromion. Shall we go for acromioplasty or not? When and how? And the long head of biceps, what to do exactly in the setting of rotator cuff tear, biceps tenotomy versus tenodesis, and he will end up with the AC joint excision in rotator cuff tear. Thank you, Dr. Hatem.
Thank you, Usama. Thanks for the introduction. Thanks, Peter, for a very nice presentation on cuff repair and the subscap repair. So while we're doing a cuff repair, we are also faced with other pathologies, and there is always debate what we should do with those pathologies. So Usama asked me to talk about these, and it's interesting what we found in the literature. So these are my disclosures, but they're not relevant to this talk. So the pathologies that we can find is the subacromial decompression, should we do that or not? AEC joint resection, biceps tenotomy or tenodesis, also suprascapular nerve decompression, and os acromial. So these are the things that you might encounter while doing a cuff repair. And the decision is when to do them, how. I'm not going to go much about the technical details, but mainly is to look at the outcomes, which will give us an idea whether to do these pathologies, deal with them at the same time with cuff repair or not. So if you take the first one about subacromial decompression, there's a lot in the literature. Most recent, this is a retrospective study comparing 107 patients with or without subacromial decompression while they are doing the rotator cuff repair. So they found that the first 2 to 5 years, the actual patients with the subacromial decompression did better. But then after 5 years, the ones that did not have a decompression, the scores were increased further. This is another study that was slightly older. It looked at small and medium cuff tears, prospective. They compared 120 patients, and they found in the study all types of acromial shapes, the flat, the curved, even the hooked ones. They followed the patients up for about 35 months, and they found there's no difference in the shoulder scores, the American shoulder elbow constant, the UCLA, no difference in range of motion. They found a slightly less rate of re-tear in the decompressed group rather than the non-decompressed group. This is a systematic review and a meta-analysis. They looked at 4 RCTs, about 370 patients, again, comparing the shoulder scores. Again, no difference in the scores and no difference in the reoperation rate, whether they did a decompression while they're repairing the cuff or not. So for the decompression, sometimes you go in, you can see this is the right shoulder, you can see the cuff tear, and you can see a very frayed, impinged lower part of the acromion and coracoacromial ligament. And to me, that's an indication there's a pathology here and we should decompress that. The decompression itself, after you use the radiofrequency to expose, the actual decompression doesn't take time. This is live, uncut, and you can see it takes less than a minute probably to decompress the acromion. So it's not a time issue, but it's a matter of disrupting the CA ligament and the CA arch. So the verdict for subacromial decompression from the literature that there is no difference in the results whether you do a decompression or not. My personal technique is that I do a decompression in most cuff repairs unless it's a traumatic case and I go in and I see there's no signs of impingement on the acromion, and thus I would not touch it. And usually at that time you find a large subacromial space. But in a lot of times you find the acromion overhanging, not only anterior, but laterally, that it actually makes more difficult during the cuff repair, and the decompression is more helpful. So this is for decompression. The next point is AC joint resection. Should you resect the AC joint or not? Now, this study, they looked at 800 rotator cuff repairs. They found that on the MRI, 60% of the patients had osteoarthritis of the acromioclavicular joint. From those, 37% were symptomatic. So that's about 22% of the total 800 patients had symptomatic AC joint symptoms. None of these patients had AC joint resection. So they just repaired the cuff, followed them up for up to 46 months, looked at the visual nerve score, tenderness, cross adduction, and the shoulder scores. And they found there is no difference in the shoulder scores for the symptomatic ones or the ones that had MRI positive findings with the ones that did not. They all had diminished local tenderness after the operation, and they only had 1% revision for AC joint osteoarthritis, 2 in one group and 3 in the other group. So it's a very small number of revision cases, but if this number is acceptable, then potentially we should not be dealing with AC joint. Another paper looked at 200 patients. This was from a French group, prospective multi-center RCT, comparing should they deal with an AC joint or not, 1 year follow-up, and they found that the ones that had an AC joint actually did worse than the ones that did not have an AC joint resection, especially if the resection was over 11 millimeters, and on ultrasound, when they reviewed their cuff, actually even the failure rate was higher for some reason. This paper looked at AC joint resection in symptomatic patients only. So 58 patients, all had X-ray findings of AC joint arthritis, all had local tenderness, and all had improved symptoms with an injection preoperative by 1 day. So they had a local injection, improved pain from the local injection preoperatively. And they randomized them into a group with AC joint resection and a group with no resection, although they had all the above findings. But again, no difference in the shoulder scores, and the local tenderness improved in both groups, the one that had resection and the ones that did not. So the verdict for AC joint resection with cuff tears is there is no difference whether you do the AC joint or not, even in asymptomatic AC joint. And to me, it's slightly surprising. Some of the papers, as you say, are suggesting a very small revision rate. My personal technique remains that if it's locally tender with an MRI finding of an AC joint, I prefer to do the AC joint resection because our patients here do not accept a revision rate. They want one surgery. They do not want the possibility of revision if possible. So if I see this pathology combined with preoperative and MRI, then I usually proceed with AC joint resection. Then we come to the biceps tenotomy with cuff repairs. So this paper looked at 140 cuff repairs. 36% had biceps pathology. And of course, that was increased in large massive tears and upper subscap. And that makes sense because we know the upper subscap is related to the pulley of the biceps. The duration of the tear was not related to the incidence of biceps pathology. And all of these patients had cuff repair, some of them without pathology, and the ones that had a biceps pathology had a tenotomy. They found that after 2 years, both groups had outcomes. So when you have a biceps pathology, you deal with it, they're as good as the ones that did not have any biceps pathology. This paper had also 80 patients, 1 year follow-up. They had a group of tenotomy, group of tenodesis, and group without any biceps pathology. They looked at the shoulder scores. And of course, the biceps one, they had initial worse shoulder scores. But the eventual follow-up showed that these patients that had either tenotomy or a tenodesis had better outcomes than the ones that without the biceps. This one compared tenotomy versus tenodesis. What should you do when you have a cuff repair? 65 patients were randomized, follow up with a constant score, and they found no difference, but as expected in the Popeye sign was higher in the tenotomy group. But then a later study, again in 2015, 150 patients were randomized between tenotomy and tenodesis, 2-year follow-up, no difference in either the shoulder score or the Popeye, the cramping, or elbow function. And they found that tenotomy gives you a faster pain relief and it's a much quicker recovery than the tenodesis. This one compared arthroscopic cuff repair with arthroscopic or open biceps tenodesis. So the mere comparison, should we do an open or an arthroscopic biceps tenodesis? They looked at the results from 6 US states, 3,600 biceps tenodesis. 78% had arthroscopic biceps tenodesis, only 22% had open biceps tenodesis. And the arthroscopic was slightly shorter in time, about 9 minutes, more common in females, more common when they had arthroscopic AC joint resection, but it added $5,500 to the cost of the operation. Surprisingly, the decompression added $10,000 to the cost of the operation. AC joint resection added $3,000 to the cost of operation. So with this, and known that the outcomes of open and arthroscopic biceps tenodesis the recommendation that you can save $5,000 by doing it with an open biceps tenodesis. Now, this is an example. It's a right shoulder, and you can see the actual cuff. You can see the biceps tendon, and it's completely subluxable. We have the supraspinatus tear on the side. We can see the biceps is frayed, degenerative. It's grooving the humeral head a little bit. There is a small upper subscap tear, and you can see that the pulley is injured, and it's completely subluxable biceps with some inflammation in this area. So this is a pathology of the biceps that needs to be dealt with, and usually I do a tenotomy for them. If I go to a tenodesis, actually, I learned the first tenodesis technique, sub-pec biceps tenodesis, from Peter about 10 years ago when I visited him. At that time, the biotenodesis screw was not yet available back home. So we developed this technique of double tunnel technique. We do 2 tunnels at the level of the lower part of pec, with the which is the level of the musculotendinous junction, pass the biceps tendon through that, and we published that through our International Orthopaedics about 6 years ago, and we still do that till now with slightly smaller incision, but we have very good outcome with that. So the verdict for the biceps is that it's better to operate on the biceps if there is a biceps pathology. There is no difference between tenotomy and tenodesis. Tenotomy gives you a quicker recovery. My personal technique is I do a tenotomy in the majority of these cuff tears, because a lot of them are actually older age patients. If it's a matter of cuff repair in a younger patient, then then I might do a tenodesis with the technique described. Then we go on to suprascapular nerve decompression. This was popularized by Lafosse, and it was recommended to be done in retracted cuff tears. And the idea was that when the cuff is retracted a lot, the suprascapular nerve becomes shortened, becomes tethered. When you start to pull on the cuff again, you're pulling on the nerve. That increases the pain, and it's difficult in the recovery. So his recommendation was to do it in the advanced degrees. We know the PATI classification. The stage 1 is tear in place. Stage 2 retracted, but still lateral to the glenoid, and the type 3, which is the massive retracted, which is medial to the glenoid rim. This study was published by Savoy in 2016, and he looked at revision massive rotator cuff tears, PATI type 3, and he compared a group 4 Goutalier plus suprascapular nerve release with a group 3 Goutalier without a release. So a worse, more retracted degenerative muscle with a nerve release with a better, less degenerative muscle. And he found that there is no difference between both groups, in spite of that the group 1 was a much worse initial outcome score. So that, to him, that showed that releasing the nerve actually gave a better improvement for the group 1, which was worse initially. So we had published a technique also for a shortcut to suprascapular nerve in arthroscopy techniques. And we developed the 3 portals. We have the lateral portal, the nevisor, and a slightly medial portal. Our technique developed as I found it initially when I was learning, quite difficult to navigate myself to reaching the point. So the technique depends on palpating the the CC ligaments before we start. And once we can palpate that, then you just navigate your scope directly to where your switching stick is, and then you're immediately working the place. That saves on shaving all the fat pad and the synovium all through and getting bleeding till you reach the place. You just jump directly into place. And as you can see, this is the suprascapular artery, and we have the CC ligaments, and as they go down, we have the suprascapular ligament here transversely beneath the artery, and now I'm retracting it with the switching stick. Then you just bring in your basket forceps, and next to the artery, you can take out the ligament. Initially, we used to do it as a bite, but now with an open basket forceps, you just push it. It's soft enough that you actually tear the ligament directly, and it's more safe rather than actually grasping the basket forceps. And the nerve is completely released, and then you can check with the switching stick and completely bring it out from the notch. So this paper looked at PATI types 2 and 3. They had 31 release versus 36 no release. Followed up 2 years, they found no difference. But my sort of criticism for this paper is half the patients were PATI type 2. So we know that in a moderate retraction, there's not a lot of benefit of a suprascapular nerve release, but it's more related to a PATI type 3 in which there's a lot of retraction and shortage, that it might be more beneficial and as described. This is another paper by Gerber, which is quite interesting. He started a randomized control trial, and he looked at patients with a supra and infraspinatus tear with a normal EMG preoperative. He did a suprascapular nerve release in one half of them and no release in the other group. Surprisingly, I mean, not only there is no difference, but he found that the patient that had suprascapular nerve release, 3 out of 9 had worse EMG findings post-op. This is difficult, might be related to the actual technique in which the nerve was compressed, but that led him to stopping this randomized study and publishing this as it is this year. So the verdict for suprascapular nerve release, that it's slightly controversial in the literature. However, it may be useful in massive tears in the PATE 3. My personal preference is to release them when I have a retraction, massive retraction, as in PATE 3. Now, the last one is the os acromial. Now, this is something that we sometimes miss in association with cuff tears. We know there are 3 types: the metaacromion, which is the largest one. Then we have the meso-os, which is the middle part, the non-fused part, and this is the commonest type, and the small distal os preacromial. These are the 3 types, but the middle one is the most common. And I think, to me, it's missing it more common rather than how to deal with it. That's the important point. These authors, it's an earlier study, but they had 1,000 open cuff tears, and they found that it's present in 6.2% of their cases. And they looked also at the decompression cases, and they found that it's 10% of their decompression cases. So we should keep an eye for os acromial in every cuff repair we're planning. Now, this paper looked at the surgery for the os acromial, systematic review, 220 patients, follow-up for 40 months. 60% had internal fixation, mostly by screw, or half of them by screw. As we said, the meso is the commonest, over 94%. 56% had cuff repairs, and only 14 had AC joint. All the surgeries, fixation methods led to a good outcome. So this is just an MRI to show you what you can be looking for, because as I said, the most important thing in the os is remembering to look for it and finding it. And if you look at the sagittal, it should be the easiest one. If you have the acromion, you'll find like a non-union or an unfused part with a high signal. That's your os acromial. This is the normal cuff with a small cuff tear. You have the AC joint. But if you find what looks like an abnormally placed AC joint, this is probably, you should be suspicious and start to look in detail with the other images. So this is actually the os acromial. You can see it looks like an AC joint, but very, very lateral, and actually in the more posterior images than this, you should be more suspicious. So keep an eye for that and look for them. This is a case that this female, the same patient. So I actually discovered this case intraoperative once I reviewed the images. So I proceeded one of my earlier cases on the spot. After doing the arthroscopic cuff repair, we did an open tension band wiring for this os acromial, and the follow-up CT was fine. It healed nicely, and then the patient had a meta removal later on. So besides the initial slightly higher pain because of the extra procedure, but she did very well with actually healing of the os acromial. So the verdict for the os acromial, if it's very small fragment anterior, you might just excise that with a decompression. If it's large, stable, decompression might be enough, but a lot of the time it's a large unstable. You need to fix that either with a screw or a tension band wiring. So in summary, we've talked about 5 pathologies that you might find with rotator cuff repair. Acromioplasty or subacromial decompression, there is no difference in the literature to say you should do it. AC joint resection, again, there is no difference in the current literature to say that. Biceps pathology, tenotomy is currently the best. You may do tenodesis, there's no difference. Suprascapular nerve release may be done in large retracted ones. And os acromial, if it's a large fixed one, then it should be unstable one, then it should be fixed. Thank you for your attention.